Good morning to everyone. We started the other way around today, how to publish. Well, before we publish, we have to think how to design our study and what to do. And I think this is a very important step at the beginning. And you should really take enough time at the beginning when you start your project, because you will need or spend a lot of time, several years usually, to perform your studies. And you will now hear some things which will you say, well, that's obvious, we have to do it, but still it doesn't work in practice very often. So it's very important to spend sufficient time at the beginning to really think how this project will work for several years and how to spend the time, and that you finally end up with a successful publication. I will start now with what is the research question. So first thing is to find my topic. Then how can I answer the research question? Do I have the means? And then what do I need to conduct the clinical study? So the things, the resources. So the first thing usually is to do a brainstorming, to think, is there long-established practice? Is there misconception? What could be done better? We know some things in patient care does not work, and we always have problems, and a lot of things. So we should think maybe this is a good chance and a good reason to do a clinical trial on it. Are there conflicting views? If you're always in the morning rounds have a discussion about a certain topic and 5 colleagues say, let's do it this way, and 5 colleagues say, no, let's do it the other way, then this may be a good reason to start a study on this topic. There may be geographical variations, so doctors in Japan do it differently than in the US, so this is also the beginning of thinking, well, maybe that's an interesting topic. And once you have your idea, don't go immediately with this idea and start your study, but challenge the idea. And the first question is, do I really want to answer the question? So I'm really motivated. There may be really good questions, but that's not my topic, that's not my thing. Maybe I'm an interventional cardiologist and do not want to do a study on pharmacotherapy, or I'm non-interventional, want to do a study on cardiovascular pharmacotherapy. So really think about, are you the right guy to do it? Are you motivated for several years to spend your time on this topic? Does it have an implication for patient care? Of course, the clinical relevance is very important. We can do many studies where we get really interesting results, but it does not impact patient care. So then you will have finally problems to publish this study and to find people and colleagues who are interested in this study. Did no one answer the question so far? That's a very important topic. So it's about novelty. Are you really the one who is making a new study with a new research question? There are many questions answered, but usually when one question is answered, 3 new questions pop up. So really think about it. Maybe your question is good, but maybe you need to modify it to find really the niche for your study. Is there a possibility to answer the question? Is it feasible? So you may end up, for example, with a sample size calculation of 50,000 participants, and of course it's not feasible, or you want to compare with some intervention which you cannot randomize because it would do harm to the patient. So there are several things which you have to take into account when thinking about it's really feasible. Is it ethically sound? For example, you have 2 interventions which you do not know at the time of starting the study if they're really comparable and have the assumed same benefit to the patient, which is called equipoise. So only in this situation you can really compare 2 interventions. And of course, you cannot do an intervention on risk factors, for example, on smoking. You can just do observational studies. Do I have the means to answer the question? Do I have the resources? This means not only financial, do I have the technical things, do I have the staff? And this is the most important thing. You really need a study team. You need the study team for several years. It does not help if you're a very motivated study team say, yes, let's do the study. But you know after 3 months everyone is gone and you do not have any study team anymore and need several more years to finish the study. And of course, you also have to think, do I have the expertise really to perform the study? You have to finally convince the scientific field that you have the studies done in a very good way. And if the field believes you have the expertise, the field will believe you. So the usual way is discard 9 out of 10 ideas. There are enough open research questions, don't worry, but do not go into the first idea which you had after brainstorming. When you are finally convinced that this is really your best research question, then the next thing is to challenge it in daily practice. Think about it when you do patient care. Think about, well, what would change if this question is answered. Ask your senior researchers in your institution. Go into literature research, including guidelines. They help you to identify open questions, so they help you to find out whether this is really a new question. And also think, what can I learn from the already published studies, and do I, for example, need to modify my topic? And of course, you have also to look at trial registers to find out if there are ongoing studies which have not been published on this topic, like clinicaltrials.gov or WHO website. So here we have an example. Sorry, it's pretty small, but I will read it to you. It's an example of guidelines, of aortic disease guidelines from 2014, and they identified major gaps in evidence. And if you go through it, then you really should think about starting to do research in aortic diseases, because there's no evidence. There are more gaps than evidence, actually. So they say we need more epidemiologic data on acute aortic syndrome. There's more evidence needed on the case load outcome relationship, so how many cases you do and how the outcome of an intervention is. We need to assess the value of biomarkers, should be clarified. More data of accuracy and reproducibility of aortic measurements are needed. We do not know about data for female patients. We have a lack of evidence of the efficacy of medical therapy. We need randomized studies when to do intervention. So there are many questions. So do not worry that there are no open gaps. There are a lot of open gaps, and this is just one small example. What you shouldn't do, and Stefan Nageval already alluded on this, you shouldn't do any fishing expeditions, search for significant association in existing database without a research question. Of course, it's important to go into existing databases, but go into this database with a question, with a hypothesis. Don't do just 1,000 statistical tests. We will hear, if you do 1,000 statistical tests, by chance just 50 get positive, so you get 50 significant results. But the question is, what is the meaning of these 50 positive results? So don't do this. It's okay, and it's important to go in retrospective databases or the retrospective analysis of databases, but then you should go with an hypothesis, what you want to find. If you find it, it's hypothesis generating, you have to prove it then finally in a prospective study. And the second thing which often occurs at the beginning, that you say, wow, I have a question that is easy to answer, I have my publication soon, but then you want to publish it and not of interest for anyone. So be careful about think, really, is this something new and people could be interested in these results. And once you have your idea, you have challenged your idea, you have looked into literature and you say, okay, that's it. Then you have to think about the research question. So you have to go now from your idea into the research question. You need to think about the time, the place, and the patients which you need to answer your research question, called also hypothesis. And you also have to think about the exact aims and the sub-aims. Let me give you an example. It's about apples. So my idea is green apples keep the doctor away. Many people think that's right. So my research question may be, do green apples prevent myocardial infarction? So you get more specific about it. And the aim with a green apple, so you say the dose per day prevents myocardial infarction. You define your patient, inpatient with high cardiovascular risk. And then you can also think about sub-aims, whether green apples lower the risk of myocardial infarction in patients with hypertension or in patients with hypercholesterolemia, whether the apple intake must be for 1 month or for 12 months, or whether green apples prevent ST elevation infarction or non-ST elevation infarction. So you really have then to also think about your sub-aims to finally get from your idea to the research question. So we have our research question now, we are happy, but now the second step begins. How can I answer the research question? We have to think about the study design. about the study population. We have to think about the exposure, so what influences the outcome, and then we have to think how to assess the outcome, meaning the endpoints and the follow-up. And then what do I need to conduct? A clinical study. Let's start with the study design. If you can decide to do an interventional study, there you have the gold standard as the randomized control trial. We will talk a lot of it in this course. We'll also talk about the analysis of randomized control trials. You need a control group, which should receive the standard therapy, or if there's no standard therapy at this time, then you give the patient a placebo. You need to do randomization, so ensure that the treatment groups are only different with regard to the intervention. So just by chance, patients go into one of the at least two groups. In an observational study, this is the other opportunity. You can test an association of a risk factor with an outcome. There you have to decide to do a cohort study, which means you start with a cohort and you wait for an event to occur. This works fine, for example, in heart failure, because they have a lot of events, so you can wait for the event to occur. Do not do it in any very rare event, because you will wait for a very long time and no event will occur. So cohort studies work fine. If you have some disease, you have a lot of events, then it works. If you have a disease with a rare outcome, you should rather do a case control study, so you compare individuals with a disease to individuals who do not have the disease. So you already have some patients identified, for example, 100 patients with a rare disease, and then you compare them to a group without the disease. You could also do a cross-sectional study just to assess prevalence of disease and risk factors at the same time. And then the question is, could also be just descriptive. So this is the relationship, to assess the relationship between the risk factor and the outcome. And then you could also just want to describe, have a descriptive aims, for example, the prevalence of disease, so how many people in Austria have diabetes, for example, or the time trends, if people in Austria had more diabetes in 2017 than in 2007. So these may be some descriptive aims. And this gets now very tricky, you may also want to compare interventions in an observational trial. Usually you compare the interventions by doing a randomized control trials, but you could also try to find something out about two interventions in an observational trial. But then you have to think about bias and confounding, and we will talk about and focus on bias and confounding now for a little while. What is bias and confounding? They're also called the enemies of sound research. So whenever you do something with your study, when you design it, when you analyze it, you always have to think, is there any bias and is there any confounding in my study, which makes the results look like they are, but actually these are not the true results. Bias means I have a systematic error that results in a conclusion which is not true. So you see something, but that's actually not true. You may have a selection bias. So this means that patient or study procedures are not comparable. So you have two groups and you compare the groups, but actually the patients in the two groups or what you do with the patients in the two groups is not comparable. You could have an information bias. The information you get from the two groups is not comparable. This is usually not by purpose, so whoever reports, the patient or the researcher who receives the information does not change the information by purpose, but it's just because of his beliefs that he sees some things differently from the two groups because they have different beliefs, for example, about different therapies. So you have a reporting bias by the participant and observing bias by the researcher. So this is bias. I will give you an example also. And then confounding means that there's a factor that affects the effect of the exposure on the outcome. So a third variable comes into the play and distorts your relationship between your exposure and your outcome. And there may be positive confounding, which means the effect seems stronger because of confounding. But if you then adjust for the confounding, the effect of the exposure disappears, or you have negative confounding, the effect seems weaker, and when you adjust for confounding, then suddenly you have an effect of the exposure on the outcome. Before we go to the example, it gets a little bit more complicated, because the study design is the important thing to prevent bias. So if you want to prevent selection bias, in an interventional trial, you have to do randomization to make groups as comparable as possible. And once you have done randomization, you also need to adhere to the protocol to make sure that they are treated in the same way, both groups. And you have to also analyze according to randomization to ensure that you do not make any selection bias. With regard to observational study, at least you could prevent selection bias by inclusion-exclusion criteria, so make your study as representative as possible for the source population, because once you have your study results, you want to translate your study results to the general population. And if you have very strict inclusion and exclusion criteria, you cannot translate the results back. And you can also try an observational trial by matching, it's called matching, so making the two groups, the two observational groups, as similar as possible in an observational trial and try to make comparisons. But as we will see, you have to be very careful about these results. With regard to information bias, in an interventional trial, you do double blinding. You should do double blinding if it's possible. If it's not, for example, a surgical intervention where it's not possible. And this prevents that the researcher or the participant influences the results and the outcome, his observation, just by knowing what therapy the patient got. In an observational study, at least you can make the participants unaware of the study aim, or the researcher classifying the endpoint unaware of the exposure of individual. Here we see an example. This was an observational trial about the effect of Dabigatran in general practice. So the rationale was the comparative safety of Dabigatran versus warfarin for treatment of non-valvular atrial fibrillation in a general practice setting has not been established. And they formed a new user cohorts of propensity score matched elderly patients. So they tried by using a score to make the groups as similar as possible. What is always good, and we see it, they had the chances among 134,000 patients with 37,000 person years of outcomes in 2,700 primary outcome events. It's very easy to do matching. So you need a lot of patients, a lot of events, then it's easy to do matching because you need to select the patients. And actually, they did a very good job. Sorry, it's rather small again. The important data here, that's the standardized mean difference. If you look, it's always 0.00, so no difference at all, or 0.01. So we see a lot of variables, and it's always very similar in both groups. So they actually did a very good job. They had the chance to do it because they had a huge population. And if we continue the same for many more variables, for example, we go to CHA2DS2-VASc score, it's complete. The CHA2DS2-VASc score is identical in both groups, so there's no difference with regard to the thromboembolic risk. The Hesplat score is completely identical in the both groups, so there could not be any difference. But now there's the but only matched for known variables, so they can only match for the variables they know, so they cannot match for any variables. Like typical thing is the social status, which they do not know about the patient. So that's the limitation. You can do a very good match study, and they did it in a very good way, but still you have to be aware it's not a randomized controlled trial because it's not adjusted for variables you do not know. Here we have a second example, a not so good example, I would say. It's published in the European Heart Journal, and if you look at this, they wanted to assess a new method about non-invasive testing and CT-based method. It's called FFR. So like in the catheter, we do a fractional flow reserve measurement, but they do it by using a CT. And they said, well, we have two groups, one with a non-invasive strategy, and we compare the new method, this FFR CT-guided strategy to usual care, and then we have patients where we already have planned invasive testing, and we also compare usual care strategy compared to FFR CT-guided strategy. And if you look now at this arm with planned non-invasive test, so they do not know if they go into catheter and they make their new method to assess if the patient has a significant coronary stenosis. We look at the baseline characteristics and suddenly find out that patients in the new arm, so with the new method, are sicker than the other patients. They have a higher body mass index, they have significantly more often hypertension, they already have significantly more often aspirin, and they have more often typical angina. So it's not the same. We are not comparing the same group, the same two groups. So we have to be careful. That's the first finding. We get a little bit cautious about the study. And then we look what they've done afterwards. So they now have the two groups and they compare the groups. But what do they actually do with the groups? In this new arm with FFRCT guided non-invasive testing, they did, as we expected, in all 104 patients, they did the CT. But they only did the new methods analyzed in 60 patients. So actually only in 60% of patients they used the new method in the study. And 40% of patients just got the CT, a coronary CT. So only 58 to 60% of patients underwent this new FFRCT in the new group. So they didn't do actually what they claimed to do in the new group in all patients, but only in 60%. And then it's always good if you do a critical appraisal, go into the supplement, and then they tell you in the supplement, that's now the group where they already wanted to do invasive testing, what they really did with the usual care strategy. And then there's the surprising information, these patients are already scheduled for catheter. 50% of patients didn't have any non-invasive testing at all. So what they actually compared were 50% of patients doing no non-invasive testing at all, compared to 100% of patients doing a CT. So that's actually what's the outcome of the study. So we have to be very careful about the results of the study. Please.
Did they explain why they excluded some of the patients?
I think it was a methodological problem, so they couldn't do the analysis by their software. It's also that you had to send the data to a center where they analyzed, and it didn't work, obviously, for 40% of patients. So we continue now, and we come to the specific topic. That's about stork delivered babies. You're in the right course. Sorry, you will soon find out why this is the topic. It's not about storks, but you find if you go to European countries and you compare the birth rate with the stork breeding pairs, you find an association. Surprisingly, there's really an association between the storks and the birth rate in countries. So, well, do we really believe that the stork brings the babies? Usually not. That's not what we think, so there must be something wrong with this analysis. And what's wrong? It's confounding. So we have the storks here with a spurious association with the birth rate, and there needs to be some confounding. And what's the confounding? The confounding is the land area. So countries with a large land area have a lower social status, they have higher birth rate, and they have also more place for storks. So this is the explanation. And if we go in theory now, we have the exposure here. Then we have the outcome, so the stork and the birth rate, and we have the nothing happens now. And we have the confounder, which actually is the land area, which promotes the birth rate and which promotes also the stork breeding pairs. So the confounder has usually some association with the exposure, and the confounder has some influence in the outcome. A second example, which is very practical for us today, about coffee and cardiovascular mortality. So don't worry, if you think you drink a lot of coffee today, you will have a high risk of cardiovascular mortality. There are studies out which make you think that there's really an association. But if you really do a proper adjustment for adjust for confounders, you find that patients who drink more coffee have a higher chance of having of also smoking and having other confounders. So it's not the coffee. It's the lifestyle of drinking a lot of coffee, having stress, smoking, etc., which usually explains the higher risk for cardiovascular mortality, but it's not the coffee at all. So if you do proper adjustment, you do not find any relationship between coffee and cardiovascular mortality. So don't worry, don't have stress, don't smoke, but you can drink coffee, it's fine, okay? Yes?
The adjustment is actually normalizing all the other risk factors?
Yes, we go into this. You need a multivariable model and try to adjust for confounders in this model. Okay, so once again, we have the exposure, which is coffee. We have the outcome, which is cardiovascular mortality, and we have confounding. In this case, this could be stress, this could be smoking. And how do we prevent confounding? The good thing about randomized controlled trials, they avoid all confounders because they should be equally distributed. And the big thing about this also about the confounders equally distributed, I do not even know. So for example, again, the social status, which I may not know about the patient, it should be equally distributed between the two groups. So I do not have any confounding in an interventional trial, in a randomized interventional trial. And I need to do adjustment for confounders in an observational trial to avoid known confounders. But again, I can only avoid known confounders and not unknown confounders in an observational trial. Let's move to another very important topic. This is the study population. I have to think about the sample size. I need sufficient power to minimize the error due to play of chance. But on the other side, I have restricted resources and I cannot just say, well, include another 1,000 patients because this is very time consuming and needs a lot of money. And the solution is to do a sample size calculation, to think what happens with mice power. And I will show you an example. You need to get a feeling about your data, about what you can show with your data. You also have to think, when you think about the study population, about the external validity. Is the study population representative of the source population? Can results then, after you have the results, be translated back into the general population? There may be different aims, so there's no right or wrong in this, but you have to think what's your aim and then define your study population. It could be that you just want to show that a new therapy works, then usually you go in a high-risk group to ensure a sufficient number of events. That's fine, just to show that this new therapy works. Or you want to know something about subgroups because they are not represented in the large studies like women, elderly, then you have to, of course, address this specific subgroup to get information on the subgroup. Let's start with sample size calculation. There are two factors which influence your required sample size. That is the difference in risk, here shown by a hazard ratio or risk ratio, so the increase in risk in one group compared to the other group. If you want to see a large difference, that's fine. If you want to see only a threefold increase of risk, you only need a few patients, like 500 patients. If you also want to see a 50% increase of risk, you have to need a six-fold higher number of patients, 3,000 patients, to see a difference of a 1.5-fold increase of the risk in the group with the exposure. Okay, so the one thing is what is the difference I want to see, and the other thing is about the event rate. If I have a very rare event, for example, only 10%, I need a high number of patients. If I want to see, if I assess some endpoint which is very common, like with 50% of patients get the endpoint, I also need very few patients. So that's the second variable which influences the need for a sample size, is the event rate. And actually, these are very nice numbers, and we will also calculate tomorrow some sample sizes, but you have to be aware 10% is rather frequent event rate, so usually you deal with 2, 3, 4% even, so you even need a much higher number. And the important thing, which I show you here, is assess different scenarios, get a feeling of the relevant factor. Very often you see just then the authors show you with a hazard ratio of 2.0 and an event rate of 20%, I need a sample size of 539. No one knows before. You should look into literature, should look what is the event rate in previous studies, but you should also assess different scenarios because you do not know your event rate, you do not know your exact increase in risk at the start of the study. And you should get a feeling, what can I achieve with 500 patients, what can I achieve with 1,000 patients, what can I achieve with 3,000 patients, and therefore you need to do several calculations. Do a table like this, you could also do a figure or graph showing the differences in sample size according to the risk ratio and according to the event rate. And you also should really think about the consequences. It doesn't help very often you do a sample size calculation, it does not work, you change your sample size calculation and move on. This doesn't make sense. If you really do a proper sample size calculation and you find out you do not have enough patients, you have to think what to do with the study, otherwise you invest 3 years of your time and you end up with a negative result. So one solution is a multi-center trial. Think about asking your colleagues in your country, in the European Union, if they also want to do a trial like this. And you also have to take account of loss to follow-up, so you should at least think about a loss to follow-up of 10% or more, because not all patients end up, you will not end up with all patients at the end of your study. About inclusion and exclusion criteria, again, there's no right and wrong. You have to think, well, what's the correct way or the best way for my study? If you have very strict inclusion-exclusion criteria, you have a very well-defined study population, it makes the effect of the therapy more predictable, so you have internal validity. It's safer, that what's usually happens with new pharmacotherapies due to exclusion of high-risk patients. So you exclude your high-risk patient, you have your new therapy, you're not sure how good the new therapy is, so you want to be safe and exclude high-risk patients. But there's a disadvantage, it's very difficult to recruit the patients. It increases the cost, the time of recruitment, the risk of the failure of the study. On the other side, if you have very broad inclusion-exclusion criteria, it increases the external validity, so the results are valid for the majority of the general population, and of course it facilitates recruitment of patients. So again, no right, no wrong, but you have really to carefully think about each inclusion and exclusion criteria if this fits for your study. And you have also to think already of being a certain study site is a selection criteria. So if you're a university center, tertiary center, it restricts your patient selection because you do not get the general population, you get a selected number of patients. So also think about what patient you usually get in daily practice. And here, sorry, again, a little bit small, this is an example from inclusion-exclusion criteria. That's from the real-life trial. It's not specific for the real-life trial. All these studies had this inclusion-exclusion criteria, the NOAC studies, because of course this was a new therapy. It may cause bleeding, and they were afraid that they induce a high rate of bleeding with the new therapy. So they didn't have 14 different reasons. They had 14 classes of reasons why to exclude patient. Of course, they excluded patient with a high bleeding risk. For example, here there were many reasons to exclude patients. That's fine, that's okay. But still we have to think, well, here the other 14 reasons not to include patient in a real trial, but when you have your results from the study, of course you have to think, can you transfer the results to the general population? Is this also true for the patient coming to your office in daily practice? That's the restriction of doing such a restricted inclusion of patients. Another example of very restrictive inclusion of patients is the Jupiter trial. They wanted to have actually patients with an LDL cholesterol below 130 and the C-reactive protein above 2.0 milligram per liter. So they wanted to have patients with low cholesterol and a high inflammation. And they had to screen almost 90,000 patients to end up with 17,000 patients who then were finally randomly assigned to a study group. And these are typical numbers for randomized controlled trials. But again, if you then have your results and you think the results are fine, then you have to think, well, for which patient these results really count, because you excluded about 80% of your patients. So it's not valid for these 80% of patients when you have your study results. You have to think about your exposure. If you do an intervention, for example, pharmacotherapy, it's the easiest version. You can just need standardization, for example, of your dose of your pharmacotherapy, how long the patient gets the pharmacotherapy. That's the easiest one. It gets more tricky if you want to measure some biologic exposure, for example, smoking, radiation or something. You need some standardized measurement, or blood pressure is even more difficult, so you have to really think how to measure this properly and standardize. And the most difficult thing is to assess history beliefs. You really need a professional support to do a standardized questionnaire or interviews to really get the information which you want to have from the patient. So that's the most difficult thing to assess, is history or beliefs, if this is the exposure you want to assess. Then we have to think about the endpoint and the follow-up. The clinical endpoint may be a hard clinical endpoint like cardiovascular mortality. That's fine, that's easy to assess. It's more reliable, but the problem is sometimes rare. So you may think, well, I do not have the power, let's go to surrogate endpoints. That's also fine, like blood pressure lowering. You need usually a smaller sample size, but the important thing is the surrogate endpoint really a valid measure of the ultimate endpoint. So you really make to be sure that your surrogate endpoint is really closely connected to the clinical endpoint. Otherwise, it doesn't make too much sense. You have to think about your follow-up. How do you do your follow-up? Do you do visits, telephone contact, of which is of course more easy, but you do not get so many information, mortality registries. You have to think about the duration of your follow-up. The longer you get, the more endpoints you have. Very often we now have endpoint-driven follow-up, so the studies wait until a certain number of events have occurred and then they stop. If you have a shorter duration of follow-up, you have eventually close association with the initial interventions. It also depends on your intervention, how long your follow-up should be. So finally, what do I need to perform the clinical study? We need a study protocol. We need to think about study acquisition in advance. We also need to think about statistic, funding, study site ethics, study registration, study reporting. You see many asterisks, so we'll talk about these topics later on. I will focus on the other points shortly now. First, about the study protocol. You should always have a study protocol. It's like a schedule for the study, and of course you should also follow your study protocol. It should have a title and authors, of course. It should tell you the rationale for the study, the research question, your study design, your study location, your study population, so all the points we just discussed, the definition of exposure and outcome, how you analyze the data, ethical considerations, how you do data acquisition, about the study flow, and also about logistics and resources. So here you really define and how you perform your study. You need to think about data acquisition. Of course, the aim is to have complete, correct, and standardized recording of key data. You need to think which information do I need. If you have very large assessment of data, it gets very tricky, but you need your data which are important. So you have to really think carefully about each variable you want to assess. Of course, you need information about the exposure. Of course, you need information about the endpoint, and you also need information about potential confounders. You need to think, where do I get my data from? You need data forms for standardized data acquisition with coded answers. So already do coded answers. You can easily transfer to already do it in a computer. You need to think about questionnaires with predefined questions to minimize bias, and this should encourage complete data acquisition. And it should be validated, it should be tested before you start your study. You also need to think about how to assess biometric measurements. You also need to be aware that you have a measurement error if you do biometric measurements. And you also think how I can easily transfer the data into the database. Otherwise, you may end a very long time of finally then transferring your data from several sources into your database. Some general statistical consideration, we will go into this topic in more detail later on. You have to think what is the gold standard. You have some reporting standards like the consort statement, which tell you how to do statistical analysis and how to report it. But sometimes, if you're a very specific field, you also should go at the beginning of your study, already go to the instruction of journals to find out what is really the state of the art, what the scientific field wants you in terms of analysis. For example, genetics is very tricky, and if you do a genetic study, it's wise to go at the beginning to the instruction for authors of journals to find out what the journals really want you to do as analysis, so you end up with the right analysis at the end. You should think about your descriptive statistical analysis of your analyzer relationship between exposure and outcome. Do you think there's a causal relationship like in an interventional trial? You need to think, do I do only univariate analysis or multivariate analysis? Do I need a time-dependent, independent analysis? So these are general considerations. You do not think about the specific test so far, but just about the general considerations. Do I need an external validation? So if your risk factor field nowadays, usually you need external validation. So if you find a biomarker which tells you about the risk of the patient in one population, usually now, if you want to publish, they ask you for a second cohort where you do an external validation. And which patients also should be analyzed? That's an important question. We will come back to this question later on. Do I only analyze patients which really got the treatment, or as I said before, should I do analysis by intention to treat? So once I've decided the patient goes into one intervention, he's analyzed according to this intervention, regardless if he really got the intervention or not. I have to think about my resources to have, as I already said, sufficient number of patients. If not, I need a multi-center trial to have really sufficient personnel with dedicated time. So be careful about very enthusiastic team, which is always the case in the beginning. If you convince them, but you have to make sure that you really have the personnel also for a longer time for the whole study period, to have sufficient financial resources and to have the resources for the whole study period. I need to register my study. If I have an interventional trial, I need to register, for example, clinicaltrials.gov or WHO website. This avoids publication bias, so that you only get results about positive results, reports about positive results. Then you also, due to study registration, you find out about negative results. And it avoids double conduct of the same study. So if there's an ongoing study already on this topic, you find out, and you do not do double conduct on the same question. And this is an important thing, if you do study registration, you should already predefine your sub-analysis to prevent phishing experiments. So if you need already to define at this stage what analysis and sub-analysis you want to perform. So let me conclude. Before you start the venture of a clinical trial, challenge the idea. Do not go into the first idea you have. Challenge the idea. Check your resources. Make sure that you really have not only the financial resources, but also the people, the study team doing the study, and have the adequate expertise. So really the scientific field believes you when you publish the results. And always have a study protocol. Thank you for your attention.